Good evening, everyone. How are you all? Welcome to First Aid AMC MCQ. I am Dr. Arshan, and I'm one of the coordinator for your 5 months MCQ course, right? So let us welcome you again to this 2 weeks free session. And tonight we are going to discuss cardiology. So cardiology is one of the most important topics for your exam. And tonight you are going to see that how we take our medicine classes. So as you are aware that this is a part of your free session. And that means that you are already taking our course classes, right? So because our course started on 6th of December, and the first class we had just on that 13th of December, which was your tips and tricks to solve the MCQs. So that was your first class of free 2-week session. And then today we are going to do cardiology. There will be another class on cardiology. We will try to finish cardiology with these 2 sessions. And then you will also have a cardiology question solvation with us. So if you are remembering, then you might remember that we discussed about, we do some theory session, and based on those theory topics, we do some question solve class. Not only that, you also get some random question solvation on recent sample questions, which will be taken by Dr. Rabia. You will get 2 classes with her as part of the free 2-week session, and that will be on 22nd and 28th. All right. So the admission for our 5 months course is still going on, and it will be open for the whole duration of December. So that means another 1 week it will be open, and then we will close the admission and you will have our orientation session in January, and we will just start with the other topics that you need for your exam. Okay, so let's start. Before we start, you also remember that if you look into our MCQ group, you can see that we had a massive success in November exam. And you might have seen a couple of students writing their reviews, but it's just not only that. There are, I think, like about 30 students has passed this November exam, which is like one of the highest number of passed candidates from our course so far. So that's how we actually prepare you for your exam. And if you follow everything that we are doing, there is no way that you would fail the exam. But again, I always say that you need your part as well, which means you will have to do your hard work. If you just say, no, I will just do the classes and I will pass the exam, I will not do anything by myself, that's not the way. You will have to do your own part always, and we can always show you the path, we can guide you, but the hard work, you will have to do it anyway. Okay, but this is a doable exam. There is nothing that you need to worry about. There is nothing you need to scare about, because people pass the exam every now and then, and almost everyone pass in their first attempt, especially from our course. Okay, so nothing to worry about on that part. Follow the things that we are showing to you. Follow the important topics that we are discussing. You will be fine. All right, so you guys are hearing me properly? Any problem with the hearing thing? And those of you who are in Facebook, I would advise you to join the Zoom session from the next session if you can, because then it becomes easier for you to talk with me, or also I can easily see what's your question in the chat box. But still, if you want to be in the Facebook group, you can write it in the comment section, and then I will also have a look if you have any questions or any confusion. All right, so let's start our tonight's session, which is cardiology theory. Before starting the theory, let's have a look on a basic cardiology pathophysiology, which is important to know first. So let us watch how cardiac system works.
The normal heart has two sides, a right side and a left side, and four chambers, the top receiving chambers, or atrium, and the lower chambers, which are thick-walled pumping chambers, called ventricles. Red blood cell will come from either the superior vena cava or the inferior vena cava and enter into the right atrium. The blood then flows across the tricuspid valve to the right ventricle. The right ventricle then squeezes and ejects that blood cell into a vessel called the pulmonary artery. Pulmonary artery splits into two vessels, each going to the lungs. As that red blood cell makes its way through the lung, it returns through the pulmonary veins to the left atrium. That blood is now oxygenated. It's picked up oxygen, then goes across the mitral valve into the left ventricle, which does most of the work in terms of delivery of blood flow to the body. That blood cell is now ejected into the aorta to some organ or muscle or skin in the human body.
So that's how the cardiac system actually works. Okay. So what's about the audio not clear? Is it for everyone? It's clear? Okay. I'm not sure what's happening with Dr. Afrin and Dr. Saima. Maybe guys, just if you are using any headphone, just remove that headphone. It might become clear. Okay. All right. So that's fine. If it is clear for all of you, then I'm not worried about it. So let's move on. So let's have a look first at how cardiac system works before we move on to the cages, which is the important one is chest pain. So before we move on to chest pain, let me discuss how cardiac system works first, which is the first basic idea that you need to know. So if we draw a picture like this, let's say this is your heart, and you already know that your heart has four chambers. So this is your right atrium, that's left atrium, right ventricle, left ventricle. Now, each of these chambers has a door-like structure, which is the valve. So you know that there is tricuspid valve in between right atrium and right ventricle. In between left atrium and left ventricle, there is mitral valve. And then there are two other valve, which is pulmonary valve and aortic valve. So what happens is that the blood will come from superior vena cava and the inferior vena cava. So superior vena cava will carry all the deoxygenated or carbon dioxide blood from the upper extremities, and inferior vena cava will take all the deoxygenated blood from your lower extremities. So both superior vena cava and the inferior vena cava will drain into the right atrium. So right atrium will get all the deoxygenated blood from your body. From right atrium, through the tricuspid valve, the blood will move on to right ventricle. And from right ventricle, it will go to your lungs, right? So this is your lungs, let's say. So through this pulmonary valve, the blood from right ventricle will move on to the lungs. And which will carry this one? The pulmonary artery. So pulmonary artery will carry blood from right ventricle into the lungs. So as you can see, all this right side will carry deoxygenated blood. So right atrium, right ventricle, through pulmonary valve, and then through the pulmonary artery, the deoxygenated blood will move on to the lungs. In lungs, the deoxygenated blood will become oxygenated, and then it will be carried by your pulmonary vein into the left atrium. So left atrium will have the oxygenated blood. From left atrium, the oxygenated blood to the left ventricle through the mitral valve. And then from left ventricle, blood will move on to aorta. So let me just change the color of the pen. So from left ventricle, blood will move on through the aorta, it will go to the whole body. And the valve in here will be aortic valve. So that's how the basic cardiac system works. So deoxygenated blood will come from your extremities and it will be carried by superior and inferior vena cava. It will go to the right atrium, then right ventricle, then to the pulmonary artery. In the lungs, it gets oxygenated, and then it will be carried by pulmonary vein, which will be oxygenated blood, comes to the left atrium, then to the left ventricle, and then through the aorta, it goes to your whole body. Now, this happens with two specific things, one called systole and another called diastole. Systole is mainly when the heart will contract, which means heart will squeeze the blood out. So if left ventricle needs to send all blood to your body through aorta, left ventricle needed to be contracted or squeezed. And that squeeze is what we call as systole. Now, your heart needs to be filled with blood. To be filled with blood, your heart needs to be relaxed. So that relaxation where all the blood will flow into the heart, it is called diastole. So that's what we call as diastole and systole. So if you can just remember up to this, you are fine. The basic cardiology is up to this. There is a lot of things to be learned. We will discuss that along the way. All right. Now moving on to chest pain. So for the purpose of your cardiology preparation, you will need to follow JM 8th edition. JM 8th edition has some of the topics, especially chest pain is a topic in JM 8. We will mainly follow JM for cardiology and also a little bit from the Kaplan step to CK. And there is nothing much you will need to do apart from that. Because we are doing a medicine chapter today, remember one thing, that time to time we will also follow some Australian guideline for this. The Australian guideline that you should follow is called RACGP. So RACGP is the Australian guideline that we follow for any medicine topic. Apart from RACGP, if you need to search a little bit more and you don't get the topic in RACGP, then you can go to Medscape. All of them are free website, so you can easily learn from them. So Medscape or e-medicine is also a good guideline. Sometimes if you need a very short or brief discussion about a topic, then you go to the Med Bullets. So these are the medicine Australian guidelines that we will mainly follow. Although Med Bullet is not an Australian guideline, it's mainly USMLE guideline, but still we can follow this one. Medscape is universal. RACGP is Australian guideline. Time to time, we will also follow another Australian guideline called ETG guideline or therapeutic guideline, which is also a very important guideline for you. If there is anything updated information that we need, then we will follow the ETG guideline. ETG guideline does not come as free. So you will need, either you can make a subscription or you don't need to do that, because if there is something important, we will include that for you in our discussion. Okay, so that's the guidelines that we are going to follow for any medicine. But in a short way, if you can at least know a little bit from the JM 8th edition, you are fine with medicine. But all of these others are side by side. That means sometimes one topic might not be elaborated in JM or may not be that much good in JM, then we will follow these other guidelines. Sometimes when you need to solve question, you might not get everything in JM, then you will need to come to this guideline to find out the answer of that question. All right, sounds good? Any questions so far? Now let's move on to chest pain. So what are the differential diagnoses of chest pain? A patient can come to you with a chest pain and a lot of differential diagnosis you might have in your mind. So chest pain can be related to cardiac. So myocardial infarction, angina can be due to pericarditis. Vascular related like aortic dissection. Some respiratory causes also can give you chest pain. Very important is pulmonary embolism, pneumonia, and pneumothorax. GIT related, especially esophagitis or peptic ulcer disease. Sometimes musculoskeletal causes can be like costochondritis, fractured rib, or cervical nerve root compression. Now, you don't need to memorize any of this because question will not ask you like, what are the causes of chest pain? So you just need to know about these topics. First of all, we will discuss about some of the chest pain characteristics. So how a type of pain can give you an idea about the cause of the chest pain. Let's say if you are thinking that it is related to heart, like angina or acute coronary syndrome, like myocardial infarction, the type of the chest pain a patient will say is called, "Doctor, I'm feeling very tight in my left side of the chest." So tightness, heaviness, or pressured feeling is the usual symptoms of angina or ischemic heart disease. Now, a patient with ischemic heart disease can also have epigastric pain and nausea. So never ever forget about it that if a middle-aged patient or a high-risk patient comes to you with a epigastric pain and feeling nauseous and it's a sudden onset, don't forget to do an ECG and rule out the possibility of ischemic heart disease. If a patient comes to you with a sharp stabbing or knife-like chest pain, and patient can pinpoint the exact area of the chest pain, it is very less likely to be ischemia or infarction. A sharp knife-like stabbing pain, which gets better with leaning forward and get worse with lying down, mainly suggests possibility of pericarditis. If a chest pain sounds like angina and it lasts for more than 10 minutes, you should be worried about myocardial infarction. But if a chest pain gets better within 10 minutes with rest, it might be just a stable angina case. We will come to this detail later on, so don't get stressed about any of this. We are just moving into the topics. If a chest pain get better with nitroglycerin within a few minutes, it's most likely a transient ischemia, like either it's a angina or esophageal spasm. But if a chest pain get worse with nitroglycerin, it suggests gastroesophageal reflux disease. Okay, so these are the small tiny things will be given to your question and you need to pick it up. So you need to know about this. Sometimes a myocardial infarction patient can present with some atypical symptom like dyspnea, shortness of breath, fatigue. Now that we know some of the characteristic of the chest pain, let's talk about some of the signs. So a patient having both tachycardia and tachypnea and having a low oxygen saturation coming to you with a sudden onset chest pain, shortness of breath, and have some risk factor of deep vein thrombosis, like had a long flight and then ended up getting a chest pain, difficulty breathing, and you have got tachycardia, tachypnea, and saturation is going down, most likely you should think about possibility of pulmonary embolism. We will discuss pulmonary embolism in detail in our respiratory system, but just get an idea. If you check blood pressure in both arms and you get a difference of more than 20 millimeters systolic, then think about possibility of aortic dissection. So systolic blood pressure more than 20 millimeter difference in both arms, think about possibility of aortic dissection. If a patient with chest pain having fever, think about some infection, especially pneumonia or mediastinitis. Sometimes we also look for some abnormal heart sound or new murmur. If you get a patient with a wide physiological splitting of the second heart sound, you might be thinking about a right ventricular infarction or right bundle branch block. It's not important for the exam, so don't bother too much. But the one thing that is important, that if you get a new fourth heart sound, think about possibility of infarction. If you get a new S3, like a third heart sound, we also call it as a gallop rhythm, think about underlying congestive cardiac failure. So S3, gallop rhythm, heart failure. A new S4 or new fourth heart sound suggests angina or infarction. All right, now let's say that you have got a patient with chest pain. You have asked all the history, you did some physical examination. The next thing that we need to know is that what will be the investigation? So any patient coming to you with a chest pain, what's your initial investigation or what's your next investigation? ECG, right? So ECG will be your next or initial investigation. Now get an idea about the type of question in the exam. In exam, time to time, you will notice they're asking a couple of questions like this. So if we divide it, next investigation, they can ask you, what is the next best investigation? They can ask you initial investigation. They can ask you, what is the next most appropriate investigation? All of these suggest next means initial investigation. If there is a next, it means initial investigation. But if they're asking about some confirmatory investigation, then they will write something like that. What is the best investigation for diagnosis? Or what is the most appropriate investigation that will lead you to diagnosis? Or they will ask you, what is the definitive investigation? So there will be no next in here. So that's how you should always read the question that given in the exam, because you might know a lot about a particular topic, but if you don't read the question properly, you might just do a wrong answer, because they might ask you the best option, but you might have chosen the initial investigation. So that's why we always say that you should be very careful that what exactly they are asking in the STEM, that you should always read about. Don't just assume that this question will be like this, or this question's answer will be like this. So any patient who comes to you with a chest pain, the next investigation is ECG. And in the ECG, what we are looking for, we are mainly trying to rule out possibility of myocardial infarction. So if you say myocardial infarction, there will be some ST elevation. So that's what we look for. Some patient can have ST depression or T wave inversion. That's usually non-acute coronary syndrome, you can say. We will come to this elevation depression thing later on. So in patients presenting with acute chest pain who have normal ECG, chance of acute MI is much less than 10%. Okay, so normal ECG with acute chest pain, usually you can say that it's unlikely to be an acute myocardial infarction. But there is a type of MI which will not show you any finding, but still patient can have MI. And that is what we call as non-ST elevated MI or subendocardial myocardial infarction. So we did the ECG first, and we have looked for some of the findings that can say that is it a ST elevated MI or is it just a normal ECG. The next investigation, which is important and can definitively rule out the possibility of myocardial infarction, is cardiac enzyme. There are lots of cardiac enzyme that we can do. So we have one called CKMB, which is cardiac specific, and it is useful for early diagnosis of acute MI. The CKMB can be detectable in your blood 4 to 6 hours after onset of the ischemia, picks up in 12 to 24 hours, and get normalized in 2 to 3 days time. Okay. Now, the best cardiac enzyme nowadays that we do is cardiac troponin. Nowadays, we don't usually do CKMB, but only in some specific situation, we might need to do that. But cardiac troponin is the best investigation now, which can actually rule out the possibility of myocardial infarction. So cardiac troponin, it is the preferred marker for diagnosis of myocardial injury. You can do troponin I or troponin T. Now, cardiac troponin typically measured at emergency department, and it has to be repeated if it is normal initially. Have a look on this chart, which will give you the idea. So, as you already know that CKMB, it will become abnormal 4 to 6 hours after onset of ischemia. But it will get better within 1 to 2 days. Maximum 3 days, it might be there in your blood. But troponin, it will be elevated 4 to 6 hours after the onset of ischemia, but it will be in your blood for at least 2 weeks. All right. So my question is, let's say you have got a patient and patient having a chest pain, left-sided, sign and symptoms goes with myocardial infarction. You did a ECG. The ECG came normal. But because the chest pain was for a prolonged duration, you did a cardiac troponin. And cardiac troponin was, let's say, 3000. So it means which is elevated. So you have diagnosed the patient to have acute myocardial infarction, which is non-ST elevated MI. Now, you did immediate management. So you did a percutaneous coronary intervention. You did all the management for cardiac infarction or MI. Just 5 days later, again, patient started to have chest pain, and the pain just similar to the first chest pain the patient had. You did ECG, ECG came normal. What you are going to do next? Yes, very good, Dr. Aishwarya and Dr. Ala. Yes, CKMB. If you do the CKMB, why CKMB it will be important in here? Because this patient will have troponin elevated in the blood from the first injury that the patient had. So if you do a troponin, it might be elevated anyway. That's why to find out a post-MI infarction or a recurrent infarction within 1 to 2 weeks, usually you can do a CKMB. Because CKMB will be normal within 3 days time. So after 5 days, if you again do a CKMB and it's elevated, which means it's a reinfarction. Okay, maybe you have put a stent in one artery, but now the other artery has got blocked. So that is what we call as a reinfarction. And for a reinfarction within 2 weeks, troponin will not be that much valuable. That's the time when you will be doing a CKMB. Okay, sounds clear? So apart from those cardiac enzyme, couple of other investigations that we can do. Sometimes we can do a chest X-ray in a patient with chest pain, but it's not for myocardial infarction, but to rule out other differential diagnoses. Especially X-ray can rule out possibility of pleural effusion. It can rule out pneumonia, even sometimes pneumothorax. It can also show some finding for aortic dissection, which is the widening of the mediastinum. So you do the the chest X-ray only if you don't get anything positive in the ECG and cardiac enzymes. So we already know about some of the chest pain causes. So we know about aortic dissection, pulmonary embolism, pericarditis. Now let's have a look about some specific finding about aortic dissection chest pain. So a patient with aortic dissection will present to you with a sudden onset, extremely severe, sharp, tearing, excruciating chest pain. So the pain will be severe, like 9/10 or 10/10, and it is most of the time retrosternal, but it's sharp, tearing, excruciating, which radiates to the back. So radiating to the back is very important finding. You can get difference of systolic blood pressure more than 20 in both arms blood pressure. You can get loss of pulse in one arm, and you can do a chest X-ray where you will get widening of the mediastinum. The diagnosis is confirmed by doing a transesophageal echocardiogram. We'll come to the aortic dissection discussion in detail later on, but just get an idea about the type of the pain. About the pulmonary embolism, we already know that it comes with a sudden onset chest pain, difficulty breathing, tachycardia, and tachypnea with hypoxemia. The pain is pleuritic kind of chest pain, which means the chest pain gets worse with taking a deep breath and by coughing. Pericarditis, most of the time in the stem, they will write that patient had a recent onset of viral flu-like illness. So most of the time it's a viral illness or a virus which later on inflame the pericardium. The pain is sharp, stabbing. It's also pleuritic, which means it gets worse with coughing or deep breathing. It is relieved by leaning forward, get worse with lying down. You can get a pericardial rub on auscultation. If you do a ECG, you will get a diffuse global ST elevation in all ECG leads. But if you do the cardiac enzymes, that will be normal in this case. The pericarditis pain usually gets better with simple rest and sometimes just some paracetamol and anti-inflammatories. Okay, so that's your pericarditis. We will come to some other causes of chest pain. One of them is costochondritis, which is also known as Tidge syndrome. Costochondritis is a very common presentation of chest pain. So mainly patient will say that my chest is very sore to touch. So if the chest is tender to touch, that's the time you will think about costochondritis. And the chest pain can get worse with deep inspiration here as well. Reflux, patient will come to you with some burning chest pain and sometimes some acidic taste in the mouth or a bitter taste in the mouth. Peptic ulcer, the patient will have an epigastric pain which gets worse after eating. We know about the myocardial infarction, which is exertional chest pain lasting more than 20 minutes here, but just remember 10 minutes, more than 10 minutes, pains, angina pain getting more severe, think about MI. Pericarditis, we already know. We know about the aortic dissection. Mitral valve prolapse. Prolapsed mitral valve is common in young women. So a young woman coming to you with a transient chest pain, and when you ausculted the pericardium, when you ausculted the precordium, you found a mid-systolic click murmur. So mid-systolic click murmur in a young woman with a chest pain suggests the possibility of mitral valve prolapse. Okay, not very important, but just remember it. Okay, so now that we have an extensive idea about causes of chest pain, we will move towards ischemic heart disease, which is the most important topic here. So far, you guys have any question? The best investigation for aortic dissection will be transesophageal echocardiogram. If that is not in the option, then CT angiogram. Okay, moving on to ischemic heart disease. So ischemic heart disease, you know the type of the pain. So sometimes patient can be totally asymptomatic, and most of the time patient will be symptomatic. Symptomatic ischemic heart disease divided into mainly two types. One is a stable angina and another is acute coronary syndrome. Stable angina means that you can see that this is a coronary artery cross section, and you can see there is a buildup of atherosclerotic plaque, but still the lumen is not fully blocked, right? So when the lumen is partially blocked like this, what happens is that when you do some exertion, exercise, sometimes because of this narrow artery, patient starts to get chest pain. And then when they take some rest, the pain gets better. When they use some nitroglycerin spray, pain gets better. And that is what we call as a stable angina, which means that chest pain related to exertion, which gets better with rest or nitroglycerin within 10 minutes, that is what we will call as stable angina. A patient with a stable angina, if they don't control their diet, exercise, and don't have any medication, sometimes it can progress into acute coronary syndrome. Acute coronary syndrome has three specific types. So it can be unstable angina, it can be non-ST elevated MI, or ST elevated MI. So in all of these cases, you can see that now this is getting blocked. In unstable angina, patient's chest pain will not get fully better after taking a rest. Okay, so and the pain will last more than 10 minutes. But if you do ECG, you might not get any finding in unstable angina, but sometimes you can get ST depression or T wave inversion. So these two findings can be found in unstable angina, either normal or ST depression or T wave inversion. But if you do a cardiac enzyme like troponin, troponin will be normal in unstable angina. So that's your unstable angina. Next is non-ST elevated MI. So non-ST elevated MI, the chest pain will be prolonged. You did a ECG, ECG may be totally normal, but you did a cardiac troponin, and the troponin will be elevated. So if troponin is raised, but ECG normal, then we call it as a non-ST elevated MI. But with a chest pain, patient having ST elevation, that's ST elevated MI. For ST elevation in the ECG, you don't need troponin to diagnose it. You already know that this is a myocardial infarction just by looking at the ST elevation. Okay, so that's what we call as acute coronary syndrome, which include unstable angina, non-ST elevated MI, and ST elevated MI. Moving on to some of the risk factor for myocardial infarction. The single most important risk factor for ischemic heart disease is raised cholesterol. So LDL cholesterol is the single most important subgroup that carries risk for ischemic heart disease. The worst risk factor is diabetes mellitus, and the most common risk factor is hypertension. So you can see that how the question is coming. If they ask what is the worst risk factor for a coronary artery disease patient, that's diabetes. What is the most risk factor? Hypertension. And what is the most important risk factor? That's LDL cholesterol. Okay, now have a look at this question. A 48-year-old woman coming to your office with chest pain that has been occurring over the last several weeks. The pain is not reliably related to exertion. She is comfortable now. So it is not reliably exertion related. The location is retroesternal. Pain is sometimes associated with nausea, no shortness of breath. Pain does not radiate beyond the chest. No other past medical history. What is the most likely diagnosis? Reflux, unstable angina, pericarditis, pneumothorax, fringe metal angina. Now, the main thing is that if a chest pain is not related to exertion, it is not cardiac chest pain. So you can rule out the possibility of angina just by this line. How about pericarditis? But in pericarditis, your characteristic of the chest pain will be different, right? So you can cross that out also. Pneumothorax does not present after several weeks. So cross that also. Even if you exclude everything, still your answer will be gastroesophageal reflux. And reflux can be there for several weeks or months and months. Pain will be retroesternal, and patient might have a little bit of nausea feeling because of the reflux, but nothing else. Okay. And also remember, menstruating women virtually never have myocardial infarction. It is very uncommon for a 48-year-old with no other risk factor to have a chest pain related to ischemic heart disease. But when they become menopausal, yes, their risk becomes similar like a man. Which one of the following is the most dangerous to a patient in terms of risk for coronary artery disease? Now, the most dangerous should be diabetes, but they haven't given any option like that. So they said elevated triglyceride, total cholesterol, HDL, LDL, or obesity. According to the option, LDL is the most dangerous. Okay. But if diabetes or blood sugar was in the option, that will be your best choice. There is a new condition which causes chest pain also. So that's what we call as cardiomyopathy. Let's discuss a little bit about it. It's not super important, but just remember it. A postmenopausal woman develops chest pain immediately on hearing the news of her son's death in a war. She develops acute chest pain, dyspnea, and ST segment elevation in lead V2 to V4 on ECG. Elevated level of troponin confirm an acute MI. So ST elevation as well as elevated troponin. What you will be thinking? You will obviously think about acute MI. Then you did a coronary angiogram to find out the exact area of block. But coronary angiogram came as normal. And also no vasospasm on provocating testing. This vasospasm happens in fringe metal angina. But that's also you have ruled out. You have done an echocardiogram which reveals apical left ventricular ballooning. So what is the presumed mechanism of this disorder? Now we call it Takotsubo cardiomyopathy. It's an acute myocardial damage, most often occurring in postmenopausal women, immediately following an overwhelming, emotionally stressful event. Like this patient, right? Examples are divorce, financial issues, earthquake, lightning strike, those kind of things. This leads to ballooning and left ventricular dyskinesia, which means the left ventricle becomes weak. It does not move properly. As with ischemic disease, managed with beta blocker and ACE inhibitor, but revascularization will not help in this patient because coronary artery is normal. So the main thing about this condition is that due to a sudden, overwhelming, emotionally stressful event, there will be a massive discharge of adrenaline or catecholamine. And that will start as a chest pain, shortness of breath, and it can cause ballooning or dyskinesia of the myocardial wall. And that can come as exactly same like acute MI, like ST elevation, raised troponin. But if you do a coronary angiogram, it will not be able to find out any block. And that's your diagnosis for Takotsubo cardiomyopathy. There is no need of putting any stent in because patient does not have any block. The treatment might be just beta blocker and ACE inhibitor. Now, another question, correcting which of the following risk factor for coronary artery disease will result in most immediate benefit for a patient? The thing is that if a patient can stop smoking, that have the greatest improvement or outcome for a coronary artery disease. You just need to remember these questions. Now, let's move on to more interesting topics. So, we did an acute coronary syndrome explanation just few minutes ago, right? So you got a patient with chest pain, then you did a ECG. ECG came as ST elevation, that's ST elevated MI. We already know about it. ECG came as no elevation of ST segment, but you did a cardiac marker. Cardiac marker came as negative, which is unstable angina. Cardiac marker come positive, which suggests non-ST elevated MI. So that's what we have discussed already, right? So the main thing is that if you want to differentiate between unstable angina and non-ST elevated MI, the only thing that can do it is doing a cardiac troponin. Now, why I am discussing this again and again is that in case of non-ST elevated MI, patient does not have a full-blown block of the coronary artery. So both unstable angina and non-ST elevated MI, those patient does not have a full blockage of the coronary artery. Still, there might be a little bit of a space where blood can flow. But in ST segment elevated MI, the artery is completely blocked and there is no blood coming out. So let's say if this is the coronary artery, this coronary artery is completely 100% blocked. What will happen to the cardiac muscle? That part of the cardiac muscle will not get any oxygen or blood and it will become infarcted. And because of lack of oxygen, this muscle will die. And that is why it is called myocardial infarction. Okay. Now, because it is 100% blocked, this has the highest beneficial by doing the thrombolytic therapy. Thrombolytic therapy means either you use a thrombolytic medication like retiplase, streptokinase, or alteplase, or you do the percutaneous coronary intervention and just remove this clot and put a stent in. Okay, so those will be beneficial in ST elevated MI, but not effective in unstable angina or non-ST elevated MI. So that's important to remember. Non-ST elevated MI, you don't need to do a thrombolytic therapy. Now, we know about this characteristic of the ischemic pain. We know that the stable angina usually gets better within 10 minutes, acute coronary syndrome more than 10 minutes. The provocating factor can be physical activity most of the time. Along with the chest pain, patient can have shortness of breath, nausea, sweating, dizziness, fatigue, lightheadedness. The type of the chest pain can be squeezing, tightness, heaviness, pressure, not burning, not sharp, pins, stabbing, or knife-like. Okay. Location is left-sided, sometimes can be substernal. Elevating factor is rest. We already know about these things, like we know that if there is a chest wall tenderness that suggests costochondritis, if patient having a chest pain radiating to the back and having unequal blood pressure between two arms, that aortic dissection, initially you can do a chest x-ray where you will get a widening of the mediastinum, and then transesophageal echocardiogram can confirm the diagnosis. Pain that get worse with lying flat, better with sitting up, pericarditis. If you do a electrocardiogram or ECG, you will get widespread ST elevation. Epigastric discomfort, pain better when eating. That's duodenal ulcer disease. If pain get worse after eating, then gastric ulcer disease. How to confirm the diagnosis? By doing an endoscopy. Now, we know about the myocardial chest pain already, right? And we know that initially we do a ECG and cardiac enzyme to confirm the diagnosis. Now, the other important topic is if a patient having angina, not myocardial infarction, how are you going to investigate that patient further? So what happens is that, let's say a patient coming to you with chest pain, left-sided, but gets better within 10 minutes after taking a rest. Patient having risk factor like smoking, hypertension, family history of heart condition, you are suspicious about underlying atherosclerotic plaque. The next thing that we do to find out how much blockage has happened is called some cardiac stress testing. Now, this part is quite confusing and complicated. So make sure you understand what I am talking. If you don't, just let me know. There are lots of stress testing available case by case. The most common one is exercise tolerance test or ETT. So exercise tolerance test, it is the usual or commonly used tool to evaluate a chest pain where you don't know the etiology and your ECG is normal. Exercise tolerance test means that patient will run on a treadmill and then you will look into the ECG for any changes. Because an angina patient with resting ECG, that will be normal. But when they start doing exercise, if you can do the ECG at that time, you can see that patient having some chest pain and some ECG changes. That can confirm that this patient having this chest pain coming from the heart, or it's a cardiac origin chest pain. But the main two things that you will need, that you will be able to read the ECG of the patient. That means patient does not have any ECG changes and patient is able to do exercise. Like you should not do an exercise tolerance test in an 80-year-old patient. They will not be able to run on a treadmill. A patient who just had a knee replacement, you will not ask them to run on a treadmill. So patient needs to be able to exercise and the ECG, the baseline ECG needs to be normal before you do this stress test, okay? When you do this exercise tolerance test, you will be looking for ST depression or T wave inversion. That will give you the diagnosis. Now let's say, what if you cannot read the ECG? That means, let's say that patient having some baseline ECG abnormality. If a patient already has some baseline ECG abnormality, you cannot do the exercise tolerance test or ETT. The other two options will be either a nuclear scan or you can do an echocardiogram showing regional wall motion abnormalities. So if a patient having baseline ECG abnormality, the option would be do a nuclear scan, which can be thallium or cysta-MIB scan, or you can do an echocardiogram showing regional wall motion abnormalities. Now, what could be your baseline ECG abnormalities? Like patient can have left bundle branch block, patient can have LVH, patient might be having pacemaker, or patient taking digoxin. So any baseline ECG abnormality, you can't do the ETT. So what about this nuclear scan? The nuclear scan works in this way, is that a normal myocardium will pick up the nuclear scan or nuclear isotope. If the myocardium is well perfused, that part of the myocardium will be able to pick up nuclear isotope. But let's say in one specific part of the myocardium was not able to pick up nuclear isotope, same like others. So if there is a decreased thallium uptake, then it suggests that that part of the muscle is not getting enough blood supply. So there is a chance that the artery which is supplying this muscle is blocked. And that's how you can think that this patient might need further investigation to find out the exact area of blockage. Is this clear for you guys, this thallium scan? Do you guys understand what I am talking about? All good? Okay, now let's move on to the next one, echocardiogram. When you do an echocardiogram, you should be able to see that during contraction, the myocardium is moving. If there is a decreased wall motion in a specific area, which is what we call as dyskinesia or regional wall motion abnormalities, that will also suggest that that part of the myocardium is not getting enough blood supply. That's why it's not contracting like others. So any of these two, either a nuclear scan or echocardiogram, will be your choice if a patient having baseline ECG abnormality. Now, what if, so Dr. Jenny, the occasion where you do the nuclear scan, if either patient cannot, if a patient having some baseline ECG abnormality, okay? Baseline ECG abnormality, that means patient might have a left bundle branch block, some changes in the ECG, then you can't do the exercise tolerance test, then you can do this nuclear scan test. And the abnormality that you will be looking for is decreased perfusion of the myocardium. Now let's say if the patient unable to exercise, then what? If patient is unable to exercise, then you can use some alternative method to increase the myocardial oxygen consumption. That means this patient cannot do exercise or running on a treadmill. So you can give something to the patient, like you can either give dipyridamole or adenosine along with the nuclear scan, which will exactly work like patient is running or doing exercise. So it's called, you're just giving some pharmacological medication to increase the myocardial oxygen consumption. So if a patient is unable to exercise, then you do dipyridamole or adenosine in combination with the scan or in combination with the nuclear isotope scan. The other option is give dobutamine in combination with echocardiogram. So if a patient is able to exercise, then you can just do the normal myocardial scan, which is normal nuclear isotope scan, or echocardiogram while patient is doing exercise. But if a patient is unable to exercise, then you'll need to use something to make the heart running. And that can be done either you can use the dipyridamole with thallium scan or dobutamine with echocardiogram. Okay? Now this will clear up your confusion. Use of exercise tolerance testing. There is exercise tolerance test, which will be able to determine presence of ischemia in the ECG. There is exercise thallium. Exercise thallium is mainly you can do if there is a baseline ECG abnormality. Same with the exercise echo. If patient is unable or if patient having a baseline ECG abnormality, then you can do exercise echo. Okay? So think about it. Think about two things. One is if you need to do an exercise tolerance test, patient needs to have a normal ECG and patient needs to be able to exercise. If patient having abnormal ECG, then you have two options. Either you do an exercise thallium or you do an exercise echo. Now, if a patient is unable to exercise, then you can do this dipyridamole thallium or you do a dobutamine echo. Is this clear now, guys? Now, this is straightforward now. So just remember in this way, then you can easily pick up the option in the exam. Now, there is like both of them are same. The thallium and echo, you can choose any of these two. There is nothing like we can choose from any of them. It's actually patient preference also. But in exam, if you need to choose between thallium and echo, the better option will be thallium. Okay, because echo is totally subjective. Because the sonographer who is doing the echo, it's a subjective thing. But myocardial scan or this thallium scan is not subjective. You can actually see where is the problem. So it's a better idea to choose thallium than echo if you need to choose between these two. Okay, Dr. Ifa? Now let's discuss about this question. A man with atypical chest pain is found to have a normal nuclear isotope uptake in the myocardium at rest. So resting isotope uptake is normal. On exercise, there is decreased uptake in the inferior wall. 2 hours after exercise, the uptake of nuclear isotope returns to normal. What is the right thing to do? So now you will understand why we are doing all of this. There is a reason. So a patient with chest pain on rest, normal isotope uptake, but when you ask the patient to do exercise, there was a decreased wall. What does this mean? It means that during exercise, patient might getting some block, or it suggests that patient might have some stable angina or reversible ischemia, right? So this patient has reversible ischemia on the stress test. A patient who has reversible ischemia on a stress test, that's the ideal candidate to have a coronary angiogram. So the right thing to do is a coronary angiography. So what happens in coronary angiography? During coronary angiogram, you will insert a dye into the coronary artery. The dye will be able to show where exactly is the blockage and how much blockage is there. And based on the severity of blockage, you can treat the patient as a prophylaxis. That means you can actually prevent for the patient to have a myocardial infarction by doing this. Okay, so that's why we are doing this. All these stress tests that we are doing is because we need to find out if this patient having any reversible ischemia. So coronary angiography determines what kind of treatment this patient will need. Does this patient can be medically treated without any further intervention? Or does this patient need an angioplasty, which is the stenting? Or does this patient need a bypass surgery? So this is what will happen. So you've got a patient with chest pain, likelihood that it's a cardiac origin. You did a resting ECG. So resting ECG abnormalities, no. So there was no abnormality in the resting ECG. What you can do? The next question you will need to ask is that, is this patient able to exercise? If patient resting ECG was normal, patient able to exercise, two things are fine, then you can just do a exercise stress test. If patient was not able to exercise, then you will do the chemical stress test, which means either dipyridamole or dobutamine. If there was a resting ECG abnormalities, then you do a exercise nuclear scan or exercise echocardiogram. Okay, just like we have discussed. If you have got positive findings here, then you will do a angiography. In the angiography, if you have got one or two vessel disease, now the main thing is that if there is more than 70% stenosis, that will need surgical treatment. So one or two vessel having more than 70% blockage, patient will be getting a stent. But if a patient has got three vessel more than 70% block, that patient will need a bypass surgery or CABG. Okay, so that's how you determine what patient will need a stent, who will need a bypass surgery. All good? Any question so far? Now, before we move on, we go for a 10-minute break. Let us discuss about Holter monitoring a little bit. And after that, we will discuss how to manage the myocardial infarction, like acute MI. So far, we haven't discussed that yet. We have discussed how to manage angina, right? So after the break, we will come to the myocardial infarction management, which is the most important topic from all of these things that we have discussed. So, but before that, Holter monitoring. Time to time, you will see this option in your exam question. Holter monitor, it's a continuous 24-hour ambulatory ECG monitoring that records the rhythm of the heart. Remember one thing, Holter monitor does not detect ischemia, and it is not accurate for evaluating the ST segment. So you don't do Holter monitor for myocardial ischemia. You do the Holter monitor to detect any arrhythmia, especially if you're looking for a ventricular ectopy, tachycardia, fibrillation, flutter. For those cases, you do the Holter monitor. A lot of candidates just get it wrong. They do Holter everywhere. So Holter is mainly for if you are suspicious about any arrhythmia or rhythmic disorder, then you do the Holter. Okay. And we will take a 10-minute break now. And after that, we will move on to the management of acute MI. So Dr. Devi asks, sir, if a patient has a resting ECG abnormality, do we still need a stress testing? Now, yes, because resting ECG abnormality, if it's not a ST elevation, then the thing is that if there is only left bundle branch block or left ventricular hypertrophy, it does not mean anything, and you can't say that that patient having a myocardial ischemia or ISD based on that. So if a patient having a chest pain, resting ECG abnormality shows maybe a left ventricular hypertrophy only, or a LVBB, not a new onset LVBB. Okay, in that case, yes, you will need to do some stress test to find out that what is the origin of the chest pain, or if this is a reversible ischemia or not. Yes, when you are not sure of the chest pain etiology, then you do the stress test. That's right. All right. So that's fine then. 10-minute break, and then we will come to the management for acute MI. Thank you all. All right, everyone, let's start again. So we have been discussing about some of the chest pain related causes. We discussed about the stress testing and all. Now let's move on to management of acute myocardial infarction. Before that, I can see Dr. Oisheria has asked if patient has acute chest pain and abnormal ECG. Now the thing is that what kind of abnormal ECG that we are talking about? And if a patient having acute chest pain and that does not look like angina, but looks like a myocardial infarction, then the ECG that you will be looking for is there any ST elevation? If ST elevation is not there, then you do a troponin. If troponin is negative, that means it's an unstable angina, right? In that case, yes, for an unstable angina, you will do a stress test, because that might show a reversible ischemia, and then you can just follow the approach that we have done so far. But if the abnormal ECG shows a ST elevation, then the patient needs to be treated for that. And obviously, we will not need to do a stress testing. We are coming to that management of acute AMI right now. Okay. So if a patient has got acute myocardial infarction, either it's the ST elevated AMI or non-ST elevated AMI, the management will be more or less same. Just the definitive management will be different, but the initial management is same. Every patient who has got acute AMI, we always follow a initial monotherapy. Mona, M for morphine. Morphine is for pain management. O for oxygen. If oxygen saturation less than 94, you will start oxygen. Nitrate. If chest pain does not get better with morphine, then nitrate will be your choice. But nitrate, you should not give nitrate to a patient who has hypotension, who is on sildenafil or Viagra. Those patients you cannot give nitrate. And the best option is giving the aspirin, which is a 300 milligram aspirin at a time. So among all this monotherapy, aspirin is the most important thing, and it has life-saving approach. So you can save the life of a patient by giving this small aspirin tablet. So among all the treatment, if aspirin is not given, you should offer this aspirin at the first. In all other cases where patient have pain, we offer them painkiller first. Like someone having a back pain, you can offer them a paracetamol. But for a chest pain, which is supposed to be a myocardial infarction, the best option or initial approach is always aspirin first. Then you can do all other things, but first is aspirin. Let's do some cases, and along the way, we will learn the management. A 48-year-old woman comes to the office with chest pain that has been occurring over several weeks. Pain is not reliably related to exertion. She is comfortable, location is retrosternal. She has no hypertension, EKG normal. What is the most appropriate next step in the management? Now, what I believe that this question, what we should normally do is that, first of all, you will do a resting ECG. The resting ECG is normal. This is most likely to be a gastroesophageal reflux disease, as we have already done this case, right? But the question is, you have options like this. Remember, in your exam, you get only 5 options, not like this much option. The important thing that we normally need to find out that this patient having a chest pain that has been occurring over the last several weeks. Baseline ECG normal. The pain is not related to exertion. Do we need to think about the possibility of myocardial infarction? Not necessarily. There is no need for doing a troponin for this kind of cases, because it's been happening several weeks already. If it's an acute MI, patient will come to you with an acute onset of chest pain, which will go on for more than 10 minutes. The best option in this case will be an exercise tolerance test, because this patient, obviously 48-year-old, she might be able to do exercise unless they have written anything. She has a normal ECG. The best option, just to rule out the possibility of ischemia, is to send her for a stress test. You don't need to do anything else. So the management we are discussing in here is that, first of all, aspirin is recommended in all patients. High-risk patients should be treated with aggressive medical management, and arrangement should be made for coronary angiography and possible revascularization. Always remember, for a patient with a myocardial infarction, the first option is aspirin. After giving the aspirin, your next best approach is to call the catheter lab and the cardiologist and send the patient for a coronary angiography with a revascularization, which might be a stent. So this too is the life-saving approach. All other managements are also important, but this too has the survival benefit. Excuse me. What else we have got for medical management of MI? Antiplatelet therapy. Early treatment should be initiated with aspirin and clopidogrel with the following consideration. Now, clopidogrel is not the initial medication that you will use if a patient needs to send for coronary bypass surgery or coronary angiography. So a patient who is going for a coronary angiogram with a possible chance of revascularization, you will just withhold the clopidogrel until they have done the stenting or bypass. Because normally if you start a patient with clopidogrel, you have to discontinue clopidogrel 5 days before the coronary bypass surgery, if possible. So the main thing that you should remember, aspirin is the usual treatment, and then send the patient to the catheter lab for revascularization. How about some antithrombin therapy like heparin? Give unfractionated heparin or subcutaneous enoxaparin until angiography or for 48 to 72 hours. The thing is that sometimes we can give them heparin or like either a unfractionated heparin or enoxaparin subcutaneous. You can give it until the patient had a angiography done or for 48 to 72 hours. But heparin, again, these medications, heparin, clopidogrel, usually we start after this revascularization is done. Okay, but heparin is a very good management for a non-ST elevated MI, because for a non-ST elevated MI, revascularization is not needed. At least urgently, you don't need to send them to the catheter lab. But for a ST elevated MI, you will have to send them urgently to the catheter lab for revascularization. So for a non-ST elevated MI, it's not a bad idea to put them on aspirin, clopidogrel, and low molecular weight heparin. Okay. Now let's talk about this question. A 70-year-old woman comes to the ED with crushing substernal chest pain for the last 1 hour. An EKG shows ST segment elevation in V2 to V4. What is the most appropriate next step in the management of this patient? What will you do? Aspirin, right? Aspirin is your next step in the management of this patient. Good. So you can see here, aspirin lowers mortality with acute coronary syndrome, and it is critical to administer it as rapidly as possible. Now, this patient had a ST elevation in V2 to V4. Do we need to do a troponin first before giving aspirin? No need. Okay, because patient already got a ST elevation. You know this is a ST elevated MI. You can do a troponin if you are not sure, but that's not your urgent step or next step. Your next step is aspirin as soon as possible. Okay. Let's talk about the next one. A 70-year-old woman comes to the ED with crushing substernal pain for last hour. ECG shows ST elevation in V2 to V4. You have given aspirin. What is the most appropriate next step in the management of this patient? CKMB, oxygen, nitroglycerin, morphine, thrombolytic, metoprolol, angioplasty, troponin, lisinopril. Always remember, in exam question, if they say that they have given aspirin in a patient with ST elevated MI, the best option is send the patient for angioplasty. And angioplasty is usually done after coronary angiogram. So get it into your head that what is coronary angiogram, what is stenting or angioplasty. So a stent and angioplasty is same. Coronary angiography is a test. It's an invasive procedure where a wire will be inserted from your groin arteries into the coronary artery, and that will have a look on where exactly is the block. And when you do the coronary angiogram, at the same time, if you have got a clot or blockage, you can remove the clot, and also you can put a stent there. And that is what we call as angioplasty. Okay. Thrombolytics is a medication to dissolve the clot. Okay. So you give an IV medication and it is supposed to dissolve the clots in your body. That's thrombolytic. And coronary angiography followed by putting a stent, that is altogether known as percutaneous coronary intervention. So those are all same thing. First you do a coronary angiogram. With the coronary angiogram, you put a stent in, that is known as PCI, that is known as angioplasty. Same. Okay. All of these are same thing. So you can see the answer is H. Angioplasty is associated with greatest mortality benefit of all the steps listed in this question. All of the answers are partially correct in that all of them should be done for the patient. Again, morphine, oxygen, nitrate should be given to the patient immediately, but they do not clearly lower mortality. Okay, so the main thing is that remember, if you have got a question in the exam like this, after aspirin, the best option is send the patient to the catheter lab for a PCI or angioplasty. Now, this will be a little bit different question. A man come to the ED with chest pain for the last hour that is crushing in quality, does not change with respiration or position of his body. ECG shows ST segment depression in lead V2 to V4. Aspirin has been given. What is the most appropriate next step in the management of this patient? Now, this is not a ST. So what will you do next? If you have got a patient like this who is having chest pain for an hour, ST segment depression, your differential diagnosis should be either it's an unstable angina or it's most likely a non-ST elevated MI. The best option in here would be, if you could do a troponin here. Although 1 hour is not ideal to get a troponin elevated, but still troponin will be our next option to know that if it is a unstable angina or non-ST elevated AMI. But that is not in your option. So what will you do next? Low molecular weight heparin, thrombolytics. Remember one thing, if it is a non-ST elevated AMI, thrombolytics has nothing to do with it. Your angioplasty has nothing to do with it. Beta blocker is not the initial management for this kind of cases. And same like apiximab is usually not the first line management. So we have morphine, nitroglycerin, low molecular weight heparin. You have already given aspirin. In these situations, always remember what can do mortality save or which can reduce mortality in this patient. The option that we want to go for is called low molecular weight heparin. Why? For a patient with unstable angina, especially if it's a non-ST elevated MI, heparin will prevent a clot from forming in the coronary arteries. It will not dissolve the clot that has already been formed. When a patient has ACS, acute coronary syndrome, but there is no ST segment elevation, there is no benefit of thrombolytic therapy. That's why we don't need to go for any thrombolytics. Aspirin is not thrombolytic. Okay. Nitroglycerin, morphine, oxygen are not associated with a clear reduction in mortality in this patient. Okay. So the basic thing, remember that if it is a ST elevated MI, your first option is aspirin, and then the next option is PCI. For non-ST elevated MI, first option is again aspirin, and the next option is low molecular weight heparin. The thing is that you will give morphine, nitroglycerin, oxygen to all of these patients. But for the questions such as like this, in the exam, think about which can reduce mortality. That means which has the time benefit. If you give all of the morphine, nitroglycerin, oxygen, and then at the end you give heparin, it does not reduce the mortality. Every minute that you are wasting, the patient having more and more damage, right? So that's why this is one of the things which the time is the golden thing here. So everything that you're doing should be time-based, which has the highest benefit. You should go for that first. Okay. So that's what you can see in here, that what are the medications that we normally give in case of angina, unstable angina, and ST elevated MI. Aspirin is given everywhere, stable angina, unstable angina, non-ST elevated MI or ST elevated MI. Beta blocker nitrate also given everywhere, but not the first medication. Heparin, no need in stable angina, but yes, it has it. You can give it in here. ST elevated MI also, yes, we can give heparin, but it is usually given after twice. It means after you have done the revascularization, then you can give heparin. Thrombolytics, no role in stable angina, unstable angina, or non-ST elevated MI. It has you can go for thrombolytics if PCI is not available in ST elevated MI. Okay. There is no role for calcium channel blocker or warfarin in myocardial infarction. Now, before I answer your questions, I will just go through this first, and then if you still have a question, then ask it. Okay. I will answer all of your questions. You can write it in the chat box. But let's discuss the management of this MI first. So in a patient with non-ST elevated MI, we don't need to send the patient immediately for vascularization. The difference is important. Are you doing a thrombolytics to a patient immediately? Thrombolytics is not necessary immediately in a patient with non-ST elevated MI. Same, you don't need to send the patient urgently to the catheter lab if it is a non-ST elevated MI. But you will send the patient for a coronary angiogram even if it is a non-ST elevated MI, because that patient might get benefit from a stent put on. The urgency is the important. If it is a ST elevated MI, it's an urgent thing. If it's a non-ST elevated MI, you can wait 48 to 72 hours to send the patient for a coronary angiogram followed by definitive management. Okay, so that's what we are talking here. Early coronary angiogram within 48 hours and revascularization are recommended in patient with non-ST elevated MI and high risk feature. ST elevated MI. The pain of typical MI is substernal, diffuse with a pressure quality. We know everything about it already. We know about the findings. Let's not go into that. We know about the initial non-specific management, which is that monotherapy. You can see here, patient with a ST elevated MI usually have a completely occluded coronary artery with thrombus at the site of a ruptured plug, which means it's a completely occluded artery. This eventually leads to myonecrosis. Restoring coronary patency as promptly as possible is a key determinant of short-term and long-term outcome. The patient's outcome depends on how soon you can do this vascularization. That's why we say patient with ST elevated MI who present within 12 hours of the onset of ischemic symptom should have a reperfusion strategy implemented promptly. This reperfusion can be obtained either with a thrombolytic therapy, which is the medication, or with percutaneous coronary intervention, which is the angioplasty. Patients presenting with non-ST elevated MI will not benefit from thrombolytics. So you don't need to go for thrombolytics like atiplase, retiplase, streptokinase in a patient with non-ST elevated MI at all. Now, this 12 hours is very important to remember. There are very much confusion about this timing. So in JM, there is something written which makes everyone confused. Now, let us discuss it and make the confusion gone forever. You should remember, if it's a ST elevated MI, you can send the patient for percutaneous coronary intervention if the patient presents to you within 12 hours of onset of the pain. Okay? The problem becomes is all right, so it's not written here, but the problem is in JEM, it is written that you will need to send a patient for a PCI within 90 minutes. So we say that within 90 to 120 minutes. So just keep it as 90 minutes. So a patient needs to send for PCI within 90 minutes. The confusion is that the main writing here, it should be when a patient presents into your emergency department, when they arrive in your emergency department, you have 90 minutes in your hand to send the patient to the catheter lab. You can't delay more than that because that's your golden time. That does not mean that, let's say a patient presented to you 10 hours after having the chest pain, and now you have diagnosed him as ST elevated MI, still you can send that patient for PCI. But you will have to send the patient to the PCI within 90 minutes of entering into the door of your emergency department. Is this something which you guys are understanding? So within 12 hours of onset of the pain, you can do the PCI. But when a patient enters into the emergency department, the main thing is that you have 90 minutes to organize everything and send the patient to the catheter lab. Is this understandable? Yes, good. So patient with non-ST elevated MI they don't need any thrombolytic medication. But within 48 to 72 hours, you will send the patient for a coronary angiogram. And if the coronary angiogram shows that patient have a more than 70% of block in one or two arteries, then you will do a angioplasty in that patient. If it is more than 70% in three arteries, that patient will be a candidate for CABG. So it's not like that, like non-ST elevated AMI does not need a thrombolytic medication immediately. But that patient within 48 to 72 hours, you will send them for a coronary angiogram, and based on the result of that, you will treat them accordingly. Okay, but for a patient who has ST elevated AMI, the timing is everything. Within 12 hours of onset of ischemic symptom, the patient needs to have the PCI. Now let's say if a patient presents to you after 12 hours, what will you do? Now let's move on to this part. The choice of reperfusion therapy is between PCI and thrombolytics. PCI is the best available treatment if you can do it promptly. It has very good outcome in patient with ST elevated AMI who presents within 12 hours when compared with thrombolytic therapy. In general, a time delay of 90 minutes from the first medical encounter to a PCI is maximum desirable. So that's the 90-minute rule I was talking about. For patients presenting with ST elevated AMI at a facility without PCI access, transfer to another facility capable of performing PCI usually takes too long. For where PCI is delayed, that if you can't do the PCI within 90 minutes, or you are in a rural setting where you don't have PCI at all, then your choice will be thrombolytic therapy. Both thrombolytics and PCI should be done within 12 hours of symptom. After 12 hours, this does not have much role. That means the outcome will not be that much better. For thrombolytics, such as a streptokinase or tissue type plasminogen activator, it can restore perfusion to the ischemic area by lysing the clot. Thrombolysis benefits patients with all type of ST elevated infarction, but benefit is several times greater in anterior infarction. The greatest benefit is patient with ST elevation who has symptoms less than 12 hours. So for both of PCI and thrombolytics, the greatest benefit if you can do it within 12 hours of symptom. If you think that you are going to start thrombolytics in a patient, there are some contraindication for it. So absolute contraindication if patient having active bleeding, significant closed head or facial trauma within the last 3 months, suspected aortic dissection, prior intracranial hemorrhage or ischemic stroke within the last 3 months. And there are some relative contraindication as well. So if none of these contraindications are there, then you can go for thrombolytics. How about late presentation? Reperfusion therapy with either PCI or fibrinolysis is not routinely recommended in patients who are asymptomatic and hemodynamically stable and who present more than 12 hours after symptom onset. Other options might be CABG, especially if a patient is not a suitable candidate for PCI or fibrinolysis. That means that if it is 12 hours more than the symptom onset, by doing any of these thrombolysis, like either PCI or fibrinolytic medication, it is not routinely recommended in a patient who is stable, asymptomatic. Usually, you don't need to consider doing that. Okay? You can just manage them medically. But if patient is symptomatic, getting hemodynamically unstable, then you can consider coronary angiogram followed by CABG or stent. In patients selected for fibrinolytic therapy, clopidogrel should be given in addition to aspirin. And if you start clopidogrel in a patient after myocardial infarction, it should be continued for at least 9 to 12 months, especially if you put a stent. So let's say a patient you put a stent in, that patient needs to be on a clopidogrel usually for at least a year. Okay. So that gives you an idea about the management of myocardial infarction. Now you can ask me any question and let's discuss about your confusion. So what is the role of nitroglycerin in acute coronary syndrome? So Dr. Janie, is that nitroglycerin is a vasodilator. So in coronary, in this myocardial infarction, the coronary artery is getting blocked, right? So the blood supply is impaired. Now, if you can dilate that coronary artery, then there will be more flow of blood into your heart. So that's the role of nitroglycerin. Vasodilation and prompt the flow of blood in the blocked arteries. And Dr. Akash, is heparin given for a long period like a regular medication? No. You will just give heparin during the initial time when patient is in the hospital. After that, heparin will be discontinued. You will continue just dual antiplatelet, which is aspirin and clopidogrel. And Dr. Kubra, you might have got your answer that yes, we can do angioplasty in non-ST elevated AMI, but not as urgent like ST elevated AMI. Yes, catheter lab open 24/7. Yes, a patient, like a lot of things can happen, Dr. Akash. A patient can remain alive within 12 hours after ST elevation, but many times they can die as well. It totally depends how much infarction has happened, where is the infarction. It depends on a lot of factors. And the routine for non-ST elevated AMI is usually you will start the medical management, and then within 24-hour patient will get a coronary angiogram, but maximum you can wait until 3 days. And then based on the coronary angiogram report, further management will be done. And these slides are already in your portal if you are a part of the course, Dr. Jess. Low molecular weight heparin is usually available in the hospital, not in the GP setting. Okay, now let's talk about some of the complications that can happen after myocardial infarction. Now, a lot of complications can happen, but the important question that can come in the exam, that what is the most common cause of sudden cardiac death after myocardial infarction? That's ventricular fibrillation. Patient can develop a specific type of pericarditis after MI. That's what we call as post-MI pericarditis, also known as Dressler syndrome. So if a patient having features of pericarditis kind of pain after a MI, then you think it as a Dressler syndrome and treat them accordingly, same aspirin, anti-inflammatories. If no response, then a steroid. If a patient develop post-infarction angina after thrombolytics or PCI, should be treated with a bypass surgery. So you have done a stent put on or given a thrombolytic medication, but it's still patient developing angina-like pain after that, then you should treat them with bypass surgery. Sorry, just got out of that slide. Just 1 second. Okay. Now there is another condition called fringe metal angina. Fringe metal angina, also known as variant angina, it is very uncommon condition in which episodes of severe angina are triggered when one of the major arteries suddenly goes into a spasm. So fringe metal angina is coronary vasospasm. When there is vasospasm, patient will have chest pain, and also you can get a ST segment elevation on the ECG. But if you do a troponin, that will be negative. If you do a coronary angiogram, that will be negative. As opposed to typical angina, fringe metal angina usually occur during periods of rest, most often at night and in the early morning hour. And it happens in cluster. If you do an exercise test and routine coronary angiogram, it will give you normal result. You can do a test called argonovin, and argonovin can trigger coronary artery spasm. And if you give argonovin and patient complaining chest pain, that can confirm your diagnosis. Because this is caused by vasospasm, you will have to give something which can cause vasodilation. So treatment is with either calcium channel blocker or nitrate. All right. Now the thing is that you will never know that it is a MI or fringe metal angina until you do the full investigations. So whatever it is, if a patient having chest pain with ST elevated MI, ST segment elevation, treat the patient like a MI. And then when you do the coronary angiogram, if you get normal result, that's the time you think about fringe metal angina. And fringe metal angina can only be confirmed after doing a coronary angiogram. Okay, cool. The last case for tonight is aortic dissection. Aortic dissection, it's also very important to know about. It's a commonly asked topic in exam. So a patient will come to you with a sudden onset of severe midline retrosternal chest pain, has a tearing or ripping sensation, usually situated retrosternally and between the scapula. It can radiate to the back, abdomen, flank, or legs. An important diagnostic feature is the inequality of the pulses. So you can get a radio-radial delay, you can get radiofemoral delay. So if you measure the pulse in both arms, you will get a delay in the pulses. So inequality in the pulses is one of the important feature. Then also you remember that if there is more than 20 millimeter mercury difference of systolic blood pressure in both arms, that can be also diagnostic. Now, if you suspect aortic dissection, because patient present to you with chest pain, right? Initially, you might do ECG, you might do a chest X-ray where you can get a widening of the mediastinum, but the only confirmatory investigation is transesophageal echocardiogram. If that is not in the option, then CT angiogram will be also a good idea. 50% patients with aortic dissection are hypertensive. So you need to do a pharmacological control of hypertension. Now, before that, remember one thing. Aortic dissection has two subtypes. Let's say this is the aorta, and these are the three main arteries. One is brachiocephalic, then left carotid artery, and left subclavian artery, right? If the dissection or tear happens before this subclavian artery, so from here to here, that's called type A. If dissection happens distal to this left subclavian artery, that's known as type B. It is important because type A is very emergency, and type A patient can die. Even you might not get a chance to do surgery. So type A, its emergency surgery is the main treatment. But for type B, your initial management should be controlling the blood pressure. So manage the hypertension. How we do that? Initially, you will give a beta blocker. And what kind of beta blocker? IV labetalol will be a good beta blocker in this case. So initially you give beta blocker and then you can give a nitroprusside. You don't give nitroprusside initially because nitroprusside can cause a sudden drop of blood pressure and that can be harmful for the patient as well. So first give a IV labetalol, which is the beta blocker, and still blood pressure is not dropping, then you can give a IV nitroprusside. Okay. After that, you can go for surgery if needed in type B. And this is very important. It comes in exam. So remember what we have discussed. All good? Pulmonary embolism, we will not discuss tonight. We will discuss in our respiratory system. And that's the end of our tonight's session with Cardiology 1. In Cardiology 2, we will discuss more about valvular problem. We will discuss more about some of the other topics like hypertension. We will discuss about heart failure, very important topic. So those will be our main topics for Cardiology 2. I hope that you enjoyed our tonight's session. I know that these are confusing and complicated, but hopefully you guys got some idea so that you don't get it wrong in the exam. Any question about our tonight's session? And Dr. Balu, if PCI is not available and thrombolytics contraindicated, but too far away to refer, this is a kind of situation which will be dealt by a cardiologist. The best option would be the choice then. Maybe in that case, maybe you will need to just send the patient to the tertiary hospital by air ambulance. And usually in exam, they don't make it that much complicated, Dr. Balu. Okay. No, these are the two classes of cardiology only, and two classes more than enough for cardiology. As I say, Dr. Akash, is that this is a part of your course already. You are actually doing the course classes. So the 5 months course has already been started. These 2-week sessions are free for everyone so that they can get an idea about how we take the classes. Yes, so the slides are available for candidates who are taking the course only. And these slides are already been uploaded in your portal. If you haven't got the portal activated yet, send us a message. We'll talk to you about it. If beta blocker contraindicated, it's a tricky situation at that time. You might consider thinking about a calcium channel blocker, but usually beta blocker will not be like, it's very unusual to have a beta blocker contraindications unless patient having a severe asthma. Otherwise, you will be able, like beta blocker is a very commonly given medication for heart. Yes, the recording will be available in your portal and the free sessions recording will be available in your Facebook group and also YouTube. How to access the portal, Dr. Fayaz? If you are a part of the course, then you will get the portal access. We have already uploaded the subscription video for the software in your Facebook group. So the Facebook group is mainly for the course candidate. There is another Facebook group. If you are a part of that course group, you will be able to see the subscription video. If you haven't done the subscription in the software yet, then just watch the video and subscribe. If you are not sure about any of this, send us a message or just inbox me. I will just tag you to that section. Okay, but you will need to just open an account in our portal to access all of this. These are free for the candidates who are part of the course. Yes, that's more than enough, Dr. Akash. The topics that we will cover, it will be more than enough. All right. So any questions about the course, guys? Now, to give you an idea that as you can already understand that the 2 weeks free session is a part of our full course. So you are actually doing the course classes. Now, we had just 2 sessions so far with you, right? 1st of December, we had a psychiatry trial class. 13th, we had a tips and tricks to solve the MCQ. This is our 3rd session. The next session will be on Tuesday, 20th of December with a cardiology class 2, and all other schedules until 28th of December is already given. Now, there is a little bit of break in between because there is a Christmas break at the moment will be going on. So please make sure you go through the schedule to cover everything up. Now, the course includes everything that you need to pass this exam. There is nothing extra that you will need apart from few things that we will discuss in the class, like the handbook of AMC MCQ you will need to read by yourself. So a couple of things which you will need to read by yourself, but the other topics and everything will be discussed by us in the class. Course includes every theory that you will need for the exam. And also we discuss about the theory-based question solvation, so which you will get 1 session of cardiology in the free session as well. We discuss the recent sample questions. There is 1 class every week on that, which will be taken by Dr. Rabia. You will get her classes, 2 classes within this free 2-week session, and you will get an idea about her class as well. We will cover, you will get at least 4 to 5 years of sample questions already solved in our portal. So if you get an access to the portal, start solving those questions, go through those questions, it will give you a lot of idea about the exam questions. You get question banks free of charge. So you will need to go through the question banks after finishing these topics with us. And then in our portal, you get MCQ, just like AMC MCQ exam, which is a software-based MCQ, and you can get to know how much time you are consuming during this question solvation. There are 25 questions, 50 questions, and even 150 model tests in your portal. And those are, we are updating every month. We are adding new questions. So it's an updated one all the time. So we have team members who update the questions every month, and new questions come in the software as well. So these are all updated things, and you don't need, I would say, scan, CTG, statistics, and every other topics that you need. Okay. You get the recordings of the classes even after finishing this course. There is a total 10 months of recordings availability in your portal. The notes and the exams will be available until you pass the exam. So that's more than enough for passing your exam in the first attempt. I hope that answers a lot of questions that you have for the course, but still, if you are confused, you are worried about something, or there is a questions going on in your head, feel free to feel free to just inbox me or just send us an email. The Q banks will not be in portal, it will be given in your Facebook group. We will just add all of this after first 2-week session is over, Dr. Devi. The sample question discussion will be with Dr. Rabia on 22nd December. So after 4 days. To join the course, you will just need to inbox me, or you can also send an email. Here, the email ID is firstaidmc4536@outlook.com. Okay, so if you just email in here, you should be able to talk with us or ask any questions. Now, everything is already given in your Facebook group. So I'll just show you where to look at. Just 1 second. So if you go to the First Aid AMC MCQ website or MCQ Facebook group, so this is our Facebook group, First Aid AMC MCQ. In First Aid AMC MCQ, if you go to the featured section, you should be able to get the course details. This is just a summary of course details. If you need the full course detail, just click over here. This is our portal. And in this portal, you will be able to find out everything that you know about the course. Okay. And also we have given the email ID, everything in here. So just go through those Facebook group or this website discussions, and then most of the questions should be answered over there. Okay. All right. So let us finish it here. I will see you again in 2 days' time on Tuesday, and we'll discuss cardiology class 2. Thank you, everyone. Have a good night. Bye.